The whole purpose of this, however, is to really focus attention on acute treatment. And I think in many ways we've been using acute treatment for a very long time, but I hope I can show you some information. We can share some thoughts tonight on really what the value is of quality acute treatment, and maybe we can explore some strategies on how to improve our outcomes when we treat migraine. So here's the objectives that I've outlined for my beginning presentation. You know, and I really do want to stress that I think acute treatment is really an art form. People who utilize this well have to be very attuned to the treatment needs that they have, and hopefully in doing so they get and understand the value of what that brings. So I want to focus on the question of why effective acute treatment really matters. I'd like to introduce and talk about something called attack-based acute treatment. I'd like to look into the idea and certainly get your thoughts later in the talk on creating a personalized, effective migraine toolkit, and then look at some of the educational resources and one in particular called MigrainePro that may be useful in tracking and looking at successes with acute treatment. Well, I think it's fair to say, and especially to this audience, that nobody wants to have a bad migraine. But when it happens, most people want to be able to make it go away quickly. Obviously, they want it to stay away for a long time. They want to be able to confidently function for the rest of their day, if not longer, and they don't want to really experience any side effects. And in order to accomplish this, over 96% of people experiencing a migraine take some medication in an effort to stop it. And that's a pretty high statistic, especially when it comes to anything that people do in medicine. But how often does that really occur? How often do people get the quality results that they're looking for? Well, we don't have the best data on this, but if we look at the meta-analysis that have been done and some other things, we recognize that only 2 out of 3 attacks, 2 out of 3 attacks, people do not obtain what the International Headache Society would say is our goal, and that's to be pain-free at 2 hours. So only 1/3 of attacks are actually reaching that high mark. Now again, that's with the acute treatment of moderate to severe migraine, but truthfully, that's where the trials were done, and that's when many people do in fact treat migraine. 3 out of 10 attacks do not have headache relief. So that's where you go from moderate to severe headache down to mild or no headache, and at 2 hours, 3 out of 10 attacks don't have that level of relief. And rather disturbingly, going back to what the goals are, only 2 out of 10 have a sustained period of pain freedom that lasts at least 24 hours. So I would venture to say that we're probably not reaching the goals that we would hope for in acute treatment as often as we would like. And I'll give you one other statistic. Over 90% of the prescribed medication used to treat migraine are oral tablets. And I'm going to try to suggest that that's probably one of the reasons that we're not really achieving the kind of quality that we're looking for, hoping for when we treat migraine. So how is migraine treated today? Well, there is no algorithm for this. There is no strategy that everybody follows. And I think most of you have probably seen multiple physicians or several physicians about treatment of migraine, and you've probably gotten many different ideas and things given to you. But one of the more common ways that physicians and other healthcare professionals approach migraine is to make a diagnosis, and then they make some presumption about the severity of that individual's migraine. So they may make a diagnosis of migraine either with or without aura. Those would be the most common diagnoses. Once that is achieved, they kind of think about the impact that that person might be living with. And ironically, none of the diagnostic criteria really address the idea of impact. We do have some things like MIDAS and HIT that can help physicians, but they're rarely used. And so most of this is just sort of intuitively based saying, okay, well, I think this person has bad migraine, maybe not so bad migraine, and then based on that, they recommend or prescribe acute treatment. So if the assumption was that you had rather mild migraine, you might be recommended an OTC or a non-steroidal, whereas if it were moderate to severe, you'd be far more likely to be prescribed a triptan. And that's kind of the basis, and I think really the foundation for why most people are given oral tablets for the treatment of migraine. An alternative to this, and something that's starting to get some traction in the healthcare community, is the idea of attack-based treatment. And that is determining treatment needs by specific characteristics of each individual attack of migraine. And I think many of you in the audience can relate to this, I hope you can, that there is kind of a spectrum of migraine attacks that you may have. There may be certain attacks that you know are going to be far more disabling, far more difficult to treat. Other attacks you probably do extremely well with, and you feel as if you've got a strategy that works. And I think in the attack-based treatment paradigm, many people are seen as requiring more than one single acute treatment strategy. And I think that's the biggest distinction, that people may need several different approaches to acute treatment. So one of the premises of this idea is that not all migraines are created equal. You know, you can have, and many of you I'm sure have experienced what you would consider a mild migraine. Something you can work through, may take some simple medications, but with minimal effort, you're going to be able to do well with that particular migraine. Other migraines you might call your moderate migraine. I get through my day, but I'm likely to alter some of the things I have to do. My treatment doesn't get me back to full function, but you know, I can do it. I have to put a lot of effort and work into doing it, but I am able to function well through the day. Now, when we get to severe migraine, things start to change. You know, this is where I can perhaps make it through the day, but I will probably find that many of my activities will be affected by migraine. I will probably alter the way I would do things or would want to do things, and truly a time when I would want medication to really be able to help and rescue me from that. And then, of course, there's that very severe migraine, basically unable to function. I'm unable to get through my day-to-day activity. Now, I know this is a kind of a simplified spectrum, if you will, but the point I'm trying to really make here is that people have a variety of migraine presentations, and as such, they likely need to have a variety of different treatments. I think it's sort of intuitive for most people that the tool you need to treat a mild migraine is probably different than the tools that you need to successfully treat a severe migraine. And so having and being prepared for that is sort of the basis of attack-based care. Now, this next slide is a very busy slide, and I'm not going to try to go and read this to you. I think most of you are well aware that there's lots of ways that we perceive and feel and understand and experience migraine in our own lives. You know, some we have a very clear understanding of, we get the triggers of, such as a menstrual migraine. Most of us have probably at some point in time experienced a migraine where we wake up in the morning where the migraine's already fully advanced and we're there. On the other hand, there are those slow migraines that develop. Then there's the presence or absence of things like nausea and the sensory sensitivity that can add tremendously to the impact of migraine, and more importantly, to the challenges in treating migraine. And we'll do a little bit more. But the only point of this slide is to say that there's lots and lots, and I could have put many more, and I'm sure you could as well. So I wanted to talk a little bit about the diagnosis versus the process of migraine. I think most of us realize that migraine is diagnosed by symptoms that people experience, but what I want to do is try to put this into a congruent model of how migraine, evolves as a process. And I want to suggest that for many people, the beginning of migraine is a period of vulnerability. They're not experiencing symptoms, but they know the environment is right, and of an environment that makes it more likely for them to have migraine. The best example I can give you for this is a woman who has menstrual migraine, and she knows as it comes time for her menstrual cycle that she becomes very vulnerable to migraine, and a time that she might want to do some self-nurturing and other things to try to help protect her vulnerability. So it's not necessarily a symptom-based event as much as it is a knowledge of what puts you at risk for migraine. Same might be true for weather or air travel or many of the other things that we consider as migraine triggers. The first real phase of migraine is called the premonitory phase, and that is a group of symptoms that are non-headache in nature, but that they predict the onset of migraine, or at least the headache phase of migraine. And when they do that, we often refer to this as a prodrome. So these may be things like fatigue, tiredness, they can be food cravings, irritability, thirst, frequent urination, a wide number of different symptoms that may constitute a warning, if you will, that migraine is on its way. The next phase is experienced maybe by 25% of migraineurs, and that's an electrical phase. That's the aura. With most typically there are flashing lights, but this can be problems with sensory changes, you know, the paresthesias, numbness and tingling in fingers and around the face. It can sometimes be weakness in muscles. It can be problems with thinking or problems with speech. So a wide array of different neurologic symptoms that are characterized by the fact that they are fully reversible. In other words, they go away completely. Typically, and not always, but after the aura, if it occurs, you get a headache, and most often that has an early beginning where the pain is rather mild and you know, will start to build over time. And if you're lucky, that mild phase will not be accompanied with other symptoms of migraine, such as nausea, light and sound sensitivity, but that will develop as the pain and the intensity of the headache increases. And eventually it becomes more and more intense to the point where it can become severe. And typically, if you take your diagnostic biopsy during severe pain of migraine, you will get all the symptoms that constitute a medical diagnosis. And then as migraine goes away, the headache will resolve, but you may have a period of time that is commonly referred to as the migraine hangover. Now, my reason in telling you all of this is it can take up to 3 to 5 days for an entire attack of migraine to go from its beginning to its ending. And you can imagine in your own mind that if you're having migraine, you know, once or twice a week, there may not really be much of a beginning and an ending as migraine goes from one attack into the next. And we also know that the best time for using oral medications, we have most studies done on triptans, but I would say any oral medication is treating the headache when the pain is mild. And people will say you can't do that because you don't have all the diagnostic features of migraine. But I will tell you that in multiple studies, if a person says they're going to have a migraine when their headache is mild or during the premonitory or prodrome period, over 90% of the time they're right. So it's not likely that they're going to miss that diagnosis and the headache will just magically go away when they believe that early headache or even before that is going to be a migraine. So been a lot of studies looking at early intervention, and what I wanted to point out is the value of oral tablets in this one phase of migraine. And literally, if you treat while the pain is mild, you almost or more than double the effectiveness to become pain-free. And if you remember that earlier slide, being pain-free is something that we really want to accomplish. So if you wait to moderate to severe, you get down to that idea that only 1/3 of attacks are actually going to be able to accomplish that. So I just mentioned a little bit ago that if you look at that phase of migraine, you may not be recovering completely between one attack to the next. And this is the idea of migraine transformation. So if you look at migraine in its beginning, we have an attack. It can be very severe, but even if you do nothing, that attack is going to go away and you will return to a normal state of functioning, of neurologic recovery, until your next migraine. And then, once again, you go through that process. But for many migraineurs, as migraine becomes more frequent, they lose that. And what you see is that there is no such thing as recovery between attacks. And that's really the foundation for separating migraine into an episodic syndrome, which is where migraine typically starts and hopefully stays, and those that end up with chronic migraine, where again, the hallmark is that there is no recovery. What people return to is a low baseline headache, and superimposed on that are more significant and serious attacks of migraine. And the question then becomes, well, what are the factors? What are the things that make it more likely for migraine to go through this progression, going from an episodic pain syndrome into a chronic disease? Well, you know, one of the important things, of course, is the idea of stress. And stress is one of probably the most overused words, and I want to go on record as saying stress does not cause migraine. But any chronic condition I know where stress occurs will be made worse by that stress. So if you have high blood pressure and you're under stress, your blood pressure goes up. If you're prone to irritable bowel syndrome, those symptoms will increase. If you're prone to migraine under stress, those symptoms of migraine will increase. So it's a very important concept to understand and learn to manage. The other thing that happens, of course, is that migraine is associated with all kinds of other disorders at a much higher rate than one would anticipate looking at the the general population. And we call these comorbidities. So things like anxiety, sleeplessness, other pain syndromes, asthma, irritable bowel disease, all of those can be comorbidities. And when they're present with migraine, they make it much more likely for migraine to become more chronic and more frequent. The third thing is medication. And I'm sure everyone in the audience is well aware of the idea that if you take too much medication, it's going to make your migraine worse. And it doesn't matter what medication it is. It can be prescription medications like triptans, or it can be over-the-counter medications. All of those things have that potential. But what I want to say to you is that we need to realize that medication is a door that swings both ways. Yes, too much medication or too frequently used medication may increase the frequency of migraine. But I'm going to show you some things to suggest that medication that's not working well, acute medication, is also a major risk factor for the advancement or the chronification of migraine. And I think that's been something that has not been highlighted enough in the minds of patients and perhaps clinicians as well. And then finally, the strongest predictor of migraine chronification is attack frequency, which at the surface sounds like an oxymoron. But the reality is, if you take a network of nerves that are involved in migraine and you stimulate them and activate them over and over and over again, the threshold to activate them in the future becomes less and less and less. In other words, the more migraine you have, the easier it becomes to get your next migraine attack. And I'm sure many of you, if you've gone through this process at any point in your life, you realize that early in life, you'd have migraine infrequently, and it often took several things in the environment to precipitate that attack of migraine. When you're in chronic migraine, virtually everything becomes a trigger. The minor changes in life, changes in the weather, changes in sleep, delay of your diet, eating time, etc., all of those become the next trigger for your migraine. So this next slide, I think, shows one of the real key things that I want to drive home in the beginning of this program, and that is that suboptimal acute treatment is a significant risk factor for the development of chronic migraine. And this is a study that we were involved in, and it looked at people's failure to achieve pain freedom at 2 hours, and they used a test called treatment optimization questionnaire, and on that questionnaire only 29% of the subjects were found to have optimized or the best they could acute treatment. And then when they looked at the four groups, 4 stages of treatment optimization, they found that the highest group, the ones who were most optimized, only 2% of them in the following year developed chronic migraine. Whereas those who said that they rarely or were never pain-free within 2 hours of acute treatment were at 4.4%. And for those who said they never were pain-free by 2 hours, they were at 6.8%. 6.8% of those people went on to develop chronic migraine within 1 year. Now think about that in a disease which lasts for decades. So, you know, if you went for years and years and years without quality acute treatment, then indeed you would be at very, very great risk of developing chronic migraine. Now there's many risk factors that I didn't go through. I put this slide in here just to sort of look at this in the context of some of these things are modifiable, others clearly are not. But if we have to add anything to the list today, it is this idea that suboptimal response to acute medication is a very significant risk factor for the development of the disease of chronic migraine. So what might we do to sort of prevent this, or how might we improve this situation today? Well, one of the ways that I would suggest is that everybody with migraine needs to have a toolkit. They need to have a well thought out plan with all the appropriate tools that they require in order to manage their migraine. And I would suggest there are the 3 R's that we go here, and no, they're not reading, writing, arithmetic. They're the right medications, plural, the right formulations, plural, and the right education. Because at the end of the day, the person making the decision about treating migraine, what they're going to use, when they're going to start treatment, etc., is actually the person who has migraine. And again, the knowledge and understanding of how to use these tools is paramount to making them successful. So let's look at the right medication. You know, when a migraine starts, there is a decision-making process that we all go through saying, okay, what medicine do I use? When am I going to treat this? And how do I make that decision? And, you know, basically we need to think of what is our first line, and it may not be the first line for every single migraine we have. Again, a migraine that we wake up with in the early morning hours and we're already nauseated and we feel the pain is throbbing and well in place is a very different animal than a migraine that develops during the day. There's more of a, you know, tension in our neck that kind of grows and, you know, eventually sort of takes off to become a migraine. Very different thinking about what we might want to start with for each of those migraines. But we need a first choice. And then we need to think about, if that first choice isn't effective, what is my backup choice? What am I going to be doing next? Do I need medicines to treat symptoms? I put nausea in there and sleep, two tools, but there are certainly others that might be of value. And then ultimately, I think most people would require something that keeps them out of the emergency room. If all else fails, what is my rescue choice? And do I have this well thought out in my mind? You know, do I have a decision tree about what I choose first? What will I do next? Do I need additional medications beyond something just for migraine to control other symptoms? And if all else fails, what am I going to do to rescue myself? And I would suggest to you that no single medication is right for every patient or all attacks of migraine. And that's where this idea of a toolkit, that a person needs to have multiple tools to treat migraine. The next thing we need to consider, and this is probably the most underestimated factor of all, is that formulations matter. Finding the right formulations. Oral tablets work very, very well if people can take them early in the course of migraine. You know, they're probably close to 60% effective taken during the mild headache phase, especially if other symptoms haven't yet developed. But by the time you get to moderate, that's dropping down below, way below 50%. And by the time you have a severe migraine, you're down to 25 to 30% of attacks achieving that goal of becoming pain-free. So oral tablets have their place, but they're not for every attack or every intensity attack. Then we think about things like ways of going around the GI tract, because there's the problem with oral tablets. they don't get absorbed as migraine becomes worse and worse. So we have nasal sprays, and we have various types of nasal sprays. Some of them very hard to find today, if you can at all, but even different qualities of nasal sprays. So we have liquids, we have dry powders. There's a little typo there. Another formulation we have now is a lontophoretic delivery system that's using an electric current to drive sumatriptan across the skin and into the blood vessels without having to go through the stomach. We also have suppositories, and of course we have injections, which have been around a long time but are very much underutilized. And then we come to the idea of having the right education. And that too is individual based. You can't tell everybody with migraine that this is the way to do it. This is the decision you have to make. Much of this comes from an individual's experience, tracking with their diary, discussing hopefully with their provider as to what are the things that I need to understand and do to make my best choices around treating migraine. So initial medications are based primarily on the attack characteristics and your treatment needs. I think most of you realize a migraine that begins at night or near the evening when you may choose to use sleep as part of your treatment is very different than a migraine that begins 2 hours before you have an important presentation at a business meeting. So your treatment needs matter too, what it is that you're doing. And whether we're going to use, say, a triptan or a non-steroidal, again, the idea of a sedative or sleep, or whether there's rescue. The other thing that I would say is that many patients, at least in my experience, really don't have a clear set of what success looks like. Everybody gets the idea, I want my migraine to be gone. That would be success, but gone when and how completely, and how about your level of function? Is the headache gone, but you're so vulnerable that you're not really comfortable engaging in activity? So what does successful treatment look like? How many times do I have to treat for how many days? Those kinds of questions become very, very important. So very quickly, I just want to run through some of the liabilities and assets. I know with my phone we had a little break here, but anyway, if you look at the oral medications, they are cheap and convenient. And I would say that's the good news and the bad news, because they are less expensive, they are more convenient, and again, I'm talking about all oral medications, but they also have the highest risk of medication overuse. They do have some very significant adverse events, especially with long-term and chronic use. And of course, when you have impairment of the gastrointestinal symptom, when you're nauseated or vomiting, which is obviously characteristics of migraine, or the stomach may not really be absorbing well because there's something called gastroparesis, which is sort of a slowing of the stomach absorption and function, tablets really don't work. And I will tell you the most consistent reason that I find in my own medical practice is why people fail with acute treatment is an over-reliance on the use of acute medication. So we have liquid nasal sprays. Those are the more traditional ones. They can be useful if you have nausea or gastroparesis. They are easy, probably less convenient than a tablet, but they do have good efficacy, certainly when used early, but even later in the attack. They can be used in pregnancy. That's an advantage in adolescents and children. And they seem to have a lot less risk of medication overuse. I see very, very little evidence that nasal sprays are responsible for medication overuse. Often when they're sprayed, they end up being snorted and swallowed, and then that just makes them an oral medication. There are taste issues, and if you're really sensitive to odors, that can be a problem. Nasal discomfort, you get fewer doses per script, and of course they have same adverse events. There's a new powder delivery system that has just been approved by the FDA. It's not on the market yet. It does have studies that show that at every early time point up to 2 hours, it has statistically better efficacy than an oral tablet of sumatriptan. So Again, the speed of onset and the effectiveness of this becomes very useful. You have far less systemic exposure to drug with this system, and actually with nasal sprays in general, but they're likely to be more expensive. You still have some taste and odor, and we've not really had them in clinical practice, so there may be things we really don't understand. I mentioned the idea of the lontophoresis delivery system. This is a novel new delivery system. You have two wells, one that contains sumatriptan, the other that contains saline or salt water. And then between these two, you have a little battery and a microprocessor. And when you put this on the skin, you press a button, it sort of checks the skin, makes sure everything is properly in place, and then it starts delivering sumatriptan using an electric current, driving it across the skin and right into into the vascular system, into the blood vessels. So it totally avoids the idea of the stomach or the GI tract. So with this system, there appears to be a very low incidence of triptans. So people that have had uncomfortable sensations associated with the use of triptans may do very well with this type of a system. It is effective when there is nausea or that gastroparesis I mentioned. Again, you have a very small amount of drug exposure, in this case about 6.5 milligrams. On the other side of this, it's likely to be much more expensive than a tablet, and we have little experience, so we've got a learning curve, if you will, about this. And then we have self-administered injections. And I think everybody realizes that the most efficacious, the most effective, fastest treatment for migraine is a subcutaneous injection of sumatriptan. But reality is that less than 4% of attacks are actually treated. And yet I could argue that this is probably markedly underutilized. But at some point, we need to have a parenteral intervention. Liabilities of self-injection are a higher incidence of side effects. There's a certain inconvenience factor. People sometimes have needle phobias. And again, we have expense issues. So let's go to the third point, and that's the right education. And I'm going to promote one thing tonight, which is called MigrainePro. This is a free form of education, and it focuses at this point solely on the acute treatment. In the future, hopefully, we'll have programs devoted to chronic migraine, to medication overuse, to prevention of migraine, etc. So a lot of others, but right now this is looking at acute treatment. And it uses a format of a group of migraine sufferers, one of whom is a nurse, and the other are patients of a specific doctor, learning about their own attack characteristics, sharing information with each other, and truly inviting you as a participant in this program to go through this self-exploration using their experience and your own experience to try to create a better plan for acute treatment. Again, back to the right medication, the right formulation, and the right delivery. So you go through things like what you experience or what makes you vulnerable to migraine, what your premonitory symptoms are, etc., etc. And you calculate over time your treatment optimization score, your headache health score, which looks at how you use improved treatment to improve your life. And you create an action plan for yourself that you test over time to see if you are improving your ability to treat acute attacks of migraine. So I want to end the idea with the healthcare of the future, because I think it's changing, and I think we all realize this. You know, it used to be that your healthcare was sort of determined by finding a good doctor who had a lot of time and sort of took care of you. But I would suggest that that's not really a valid expectation today. No question that the healthcare system lacks time for that kind of development with patients. There's very little time, and a lot of your doctor's time is probably spent looking at a computer these days rather than addressing you personally or as personally as you might like. There is a time of lacking advocacy, and the reality is that medical decision making is less and less of the physician's decision. And by that I mean that we have managed care programs and better if it's managers, etc., that are actually making many of the decisions that determine care. And what I would suggest to everybody with migraine is the healthcare of the future is going to be about what patients can do and advocate for themselves. And I encourage everyone to think about, what they need, what their treatment needs are, and what they need to do to become an advocate for themselves in getting that. And with that, I am going to close my presentation and hope we'll have some time for questions. And I would love to entertain your thoughts and comments on the presentation and information tonight. Thank you all very, very much.
Great. Thank you again, Dr. Cady. It looks like our first question comes from Tina. She says, my neurologist said triggers are no longer considered real. What?
Well, Tina, that's a great question, actually, even though we kind of laugh about that a little bit. I think there's a point to what your neurologist is trying to say. When you have episodic migraine, if you remember that one chart, and migraines occur and you go back to functioning normal, it's not unreasonable at all to find some very important triggers or things that can put you at risk for migraine. I think what your doctor might have been referring to, however, is when migraine becomes increasingly chronic, there are so many things that can, quote, trigger or put you at risk for your next migraine that it becomes almost impossible to trace all that back. Even the most minor change in your environment becomes your next trigger for migraine. And what I do in my own practice is really get people to focus on the protective things that they can do for their nervous system rather than hunt for the hundreds of different things that they have found that trigger migraine. So we focus on things like regular sleep, regular meals, regular exercise, good acute treatment results, good sleep hygiene, doing recreation every day that is something that's self-nurturing, nurturing to your nervous system. And that way it probably becomes a much more palatable approach. But I'm thinking that may be where your neurologist was coming from.
Thank you. Our next question is from Patricia. She's had migraine for over 35 years. Relpax is her medication of choice, but she cannot go more than 3 days without a migraine. She's tried Botox and acupuncture. She's also using a cephally unit every day, but it isn't perfect. She actually had daily migraine for a while, but figured it out that it was a rebound headache due to Relpax. Do you have any suggestions on anything else she could try?
Well, it sounds like you've made some progress and you've got a very good understanding of migraine. And that is indeed one of the problems with acute therapy that I was trying to sort of drive at, this balance between what's too much and what's not enough. So, you said your tool was Relpax, and I think Relpax is an excellent medication, but I would question whether an oral medication really can meet and match the entire spectrum of needs you may have. It may be that for certain migraines, you would do a lot better and ultimately require a lot less medication if you had an effective nasal formulation or an lontophoretic or an injection formulation, because some of those migraines are probably associated with poor absorption. You may be already nauseated or you may awaken. And so you might revisit, what additional tools you might require. Sometimes a good non-steroidal that is rapidly absorbed, like the effervescent formulation of diclofenac. If that's taken on an empty stomach, in many people, within 15 minutes, you're getting an adequate blood level of that medication, which is very different than a tablet of ibuprofen or naproxen. So, again, you might just kind of explore that idea. What other tools for the spectrum of migraine that I have would make me more effective and ultimately require less medication?
Thank you. Our next question here is from Sam. When you grow through menopause, will migraine get any better? And also, are you more prone to dementia if you have chronic migraine. I feel so impaired since being diagnosed with migraine, chronic migraine. Sorry.
Well, Sam, I wish I had that crystal ball. I can tell you, statistically, as migraine, as we mature as migraineurs, migraine tends to sort of diminish in its intensity and severity. And I need to put the caveat in there that that is not the case for everyone, but in general, that is the case. Migraine doesn't go away. I mean, the reason that you have migraine is the genetics you're born with. And that doesn't change, and there's no way to change that. But there is sort of a tendency over time for migraine to sort of diminish in its intensity and severity. So that's good news. You made two observations that an observation, and you made had a question. Migraine, especially when it's chronic, is often associated with cognitive difficulties. The processes in your brain, and in many ways, when you're in the chaos of a migraine, the brain is not functioning well. And we've done many studies to demonstrate that there is significant cognitive impairment that can occur with migraine. So when you're in chronic migraine and migraine is occurring nearly daily, it's not unusual at all to have cognitive things. Plus, you may be taking medicines that make that worse. So the final thing you asked is, do people with chronic migraine have a greater risk of dementia? And I'm happy to tell you that the answer is no. So that has been studied and has been looked at. A very nice study by Michelle Ferrari. And I think, we're quite confident in telling people that having chronic migraine does not relate to Alzheimer's or dementia.
Thank you. Our next question is from Anne. She says, I cannot tolerate triptans. I'm literature regarding the usefulness of topical menthol and camphor for headache. I benefit very much from careful topical application of these around my left temple, cheekbone, and lower jaw. I'm wondering about the involvement of trigeminal nerve system and topical treatment for sinus, neck pain, and migraine headache. Are you aware of any literature in the field?
Yeah, actually, Ann, I did quite a bit of the original work on so-called sinus headaches and migraine and their relationship. And, it's very interesting to me that today many of the most effective things we have to treat migraine, and I want to put things such as you mentioned, are actually acting in the periphery. Even though we say migraine is in the brain, the types of medications and interventions that are being looked at and researched today are actually interacting with those nerves that are outside the brain. So, for example, Botox. We don't think Botox goes in anybody's brain. We know that it affects the nerves outside the brain, and it can reduce the frequency of migraine. You've probably seen some of the research on monoclonal antibodies, which is kind of exciting right now. But those antibodies don't go inside the brain. They, again, work on the nerves outside the brain. Looking at things like cephaly and vagal nerve stimulation, same type of thing could apply there. So, I'm sort of agnostic about a specific treatment or any specific treatment. I would suggest to each and every one of you and to myself, the way that we have to look at what's right for migraine, what's right for us is what works for us. And again, it goes back to that idea, if I set a goal for myself, am I likely to be achieving it? And that's where, you keep a diary, you keep a record, and if the topical therapy is actually achieving that, go for it. I think in that case in particular, there's probably very low risk to doing that, and if it can become a valuable tool for you, I see nothing wrong with it. But I do think on the other side of that, you want to be very objective. Are you really accomplishing those goals? And that's why it's important to define them so you can really measure them. But a very good question. Thank you.
Great. Our next question is from Joe. If you're absolutely sure that you'll get a migraine, such as when you're boarding an airplane, is it okay to take a triptan while you're still feeling fine?
Okay, Joe, that's a great question, and I can tell you there would be a lot of controversy over the answer that I'm about to give you. But I have a lot of patients who we've looked at this vulnerability phase of migraine. There is a lot of good scientific information on menstrual migraine, so women treating knowing that it's coming, so they start before the migraine does with their treatment. And I will tell you, for things such as travel on airlines, when people can bring in their diary and show me, guess what? Every time I've crossed 2 time zones in an airplane, I get there and have a migraine. And yes, we will often give them a long-acting triptan most generally, and they can take that before they get on the plane. Maybe they take a second dose once they get there, and what that allows them to do is go on and function. Now, having said that, this is totally off-label. There's no study to confirm what I just told you. I'm giving you simply my personal experience. But again, I think this is where, you know, this attack-based care, and you work with your healthcare provider who may have a different opinion than I do, but your diaries, you can bring them in, you can say, here's what I've understood about this. Is this a good strategy for me? And there may be reasons it's not a good strategy, or there may be reasons that it's a reasonable strategy to try.
All right, our next question is Karen, from Karen. If you feel like you may be overusing medications, how can this be tested?
Well, there's no perfect test for that, Karen. I mean, it'd be nice if we had a blood test that said, okay, you're in medication overuse. And, you know, very often we're kind of schizophrenic about this because we have certain quantities of medicines that we recognize are putting people at risk. So, for example, if you're taking certain medications like an opioid, a butalbital, that's a furosemide types of compounds, even combinations with containing caffeine, so the over-the-counter medications, triptans, on 10 or more days in a month, you are at risk of developing medication overuse. On the other hand, simple analgesics, non-steroidals, we typically put that at a little higher threshold of 15 days per month. Now, saying that you're at risk for medication overuse is not the same thing as saying that you have medication overuse headache. You know, in my mind, and I think the minds of most people who you know, specialize in headache, medication overuse is where the medication is worsening the underlying headache pattern. So if you're taking more and more medication and things are getting worse and worse and worse, you're probably in medication overuse. And at that point, you know, there really is no good solution except to get off those medications, let your nerve cells recover, let them build healthy new receptors, and kind of start with a new approach. And of course, that new approach, again, is finding better, more successful acute treatment, but more importantly, it centers on the use of prevention medications and interventions. And it often centers on the use of important behavioral and non-pharmacologic efforts to prevent migraine.
Thank you. Our next question is from David. Can tests such as hormone levels and metabolic panel be helpful for men?
You know, it's a great question, and again, I wish I had a lot more data, but I definitely think, you know, things like metabolic syndrome, etc., can become significant risk factors for migraine and migraine chronification. You know, a healthy body resists migraine. So I think any efforts to control these concomitant or sometimes comorbid disorders are very important. And I have no question that, you know, a healthy diet is a very important part of controlling migraine. So my answer would be yes, and I would encourage that.
Our next question is from Misty. What do you say to patients to introduce migraine diaries and to ensure that patients go to the site MigrainePro.com?
Well, they can go to a lot of other ones, and I maybe was, you know, a little too promotional, but the reason that I'm promoting MigrainePro.com is there's no charge, it's free, but what it's really trying to do is collect a lot of information that can be used to better understand migraine. So nobody is identified specifically as themselves for this, but all this information about what you experience during your prodrome, what you experience during mild headache, what treatment is working for you, what's not working for you, what's the best timing for using these things, all that will be collected and hopefully become a very usable research database in the future that helps all of us, helps healthcare providers, and obviously helps people living with migraine. So that's why, you know, I try to promote that. But there's a lot of good education that is out there. So how do I introduce diaries? You know, my standard line is, this is our report card. I'm trying to make a commitment to achieve certain goals with you. You tell me these are the goals that are important to you. We've agreed this is what we're working on. That diary becomes our record, our report card as to how well we're doing. It also helps me be more effective in the office, in the clinic, because when somebody comes in, we take out that diary, and let's just say since I last saw them, they've had 10 migraines. We'll just make that number up. And 7 of them they did great with. You know, they picked the right tool, they did the right thing, they timed it right, and they got the results they wanted. Now we're down to just looking at the 3 migraine attacks that didn't quite, you know, do or meet the mustard, if you will. And so we can start analyzing and individually saying, well, was it something unique about the presentation of this? Did we try a different strategy? What was the timing of your treatment? Did you have your backup plan or rescue plan? All of these different things, and then we refine it. And then the next time, you know, hopefully we're going to look at even fewer attacks until we sort of get it right. But, you know, it's really the center point of discussion. And again, I don't have to talk about all the times you've done really great with migraine. I'll certainly congratulate you about this. But again, we can really focus attention on the times we need to do better.
Our next request is from Salima. She'd like for you to speak a little bit more about rizatriptan.
Mm-hmm. Yeah, rizatriptan is one of the earlier triptans. It's considered one of the more short-acting. It's quite fast in its onset. It's very effective, like all the triptans. It is going to work best if it is delivered when the headache pain is still mild. And I can be very, very direct with you about this because the studies were actually done with rizatriptan. But if you can treat a migraine before there are other associated symptoms, so the only thing you're treating is a mild headache that you know will go on to become a full-blown migraine if you don't treat it, but you're not yet nauseated, you're not yet sensitive to light and sound, that drug can work, you know, 65+% of the time in getting you pain-free, which is really good. As migraine moves on, that efficacy is going to drop. So, you know, I think it's a very, very valuable tool for many, many people. And, you know, it's one that I use frequently.
Okay, our next question is from Diane. What do you think about adding medical marijuana to treating chronic migraine? I cannot take many meds, including NSAIDs.
Diane, you're setting me up on this one. I can feel it coming. You know, the truth is there needs to be very real and legitimate study about the question you just asked. I don't have an answer. I think everybody has an opinion, but there is very little quality data. You know, it's not just medical marijuana. There's the whole idea of CBDs, these cannabinoid receptors that are in our brain. They are involved in pain. I think it's unfortunate at a certain level that we're conducting the experimentation on this at a social level rather than as good science. And the only thing I can tell you is that I really wish we did have some good studies to look into the role of these compounds, these chemicals, and how they function and could help us in managing migraine.
Our next question is from Wendia. I have chronic migraines and chronic daily headache. As of yesterday, I was diagnosed with fibromyalgia. Is there a connection with chronic migraine and chronic headache?
Yeah, and fibromyalgia as well. And this, I didn't have much time to go into this, the idea of the comorbidities that people experience. The idea of migraine is that people are born, they inherit a nervous system that is genetically programmed to be more excitable, more easily activated by stimuli, either internal or external. So if you took somebody with migraine and somebody without that were identical except for that fact and put them in a laboratory, the person with migraine would, see light, hear sound, smell an odor, feel a touch at a very distinctly lower threshold than the person without migraine. Plus, when they get that information, they tend to hold on to it longer. And that's kind of the basis for how this nervous system gets overloaded by stimulations, like I said, either internally, within your body, like hormonal stimulations, or externally from the environment. And that's kind of the foundation, the balance, if you will, for migraine. So there are many other diseases that sort of fit that as well. And that's certainly true for fibromyalgia. And there's a lot of similarity between migraine and fibromyalgia. And there are people that look at this sort of hypersensitive nervous system and this whole constellation of comorbid diseases and how they may be more similar than distinct. So it's an important area of research right now. Now, having said this about the hyperexcitability of the nervous system, I always tell my patients that this nervous system also brings attributes to it. People with migraine, for example, tend to do well with school in general. They tend to often be successful with artistic effort. They tend to be very conscientious people. They're well aware of the environment around them and the feelings of other people. I teasingly say we get our own feelings hurt a little easier than other people. We tend to be light sleepers, get cold hands, cold feet. We dream in color more often, and we like to skip breakfast. So for whatever that's worth to anybody out there, the point I'm trying to make is you're going to live with this nervous system. There are good things about it, and obviously the idea of having migraine attacks is not one of those good things. It's a very potentially destructive thing.
All right, it looks like our last question that we can cover this evening is from Julie. I know there is a lot of current research going on within the CGRP. When will it be available to the general public?
Well, Julie, there is a lot of exciting stuff. CGRP has been around a long time. Actually, triptans affect CGRP. A lot of the medications we're currently using have an impact on CGRP. I suspect what you're referring to are studies with monoclonal antibodies. And basically, some very bright chemists have been able to engineer an antibody which will neutralize CGRP. Now, in the nerve cells, CGRP is stored in little packets, and when that nerve cell is activated during migraine, those little packets are released, and they contain CGRP, and CGRP sets up the inflammation around the nerves and causes the blood vessels to swell and starts the cascade of events that initiate migraine. So the idea of a monoclonal antibody or an antibody against CGRP is when the nerve cell releases it, this is a shot somebody has been given, the antibody circulates in your system, and then the antibody has an opportunity to interact and neutralize that CGRP. So the studies that are going on with this are kind of beginning. They're encouraging, but we're a long ways from knowing the answers to the important questions about their overall safety and their effectiveness. And so it'll probably be several years before this was something that would be available. And again, I have no line on knowing that. There's a lot of things that can can change in drug development, but it is an encouraging direction that migraine research is going right now. And maybe someday we will be able to go in to get shots that protect us and prevent migraine.
Well, Dr. Cady, I'd like to thank you for joining us this evening. From the comments that we're receiving, this is a very informative webinar. If you had any closing statements you'd like to make.
Yeah, well, I appreciate the opportunity, Akosa, I really do, and I apologize for whatever happened to my phone. I'm glad some people stuck it out. You know, the only thing I want to say is, you know, we're learning about migraine. A lot of reasons for us to learn a lot more about it. I think, you know, if you look at the impact of migraine, it's been estimated it's the fourth leading cause of disability in the world for women, somewhere around number 19 for men. So this is not trivial. It's a very important thing for us to be able to understand better, manage better, and I would suggest that the optimal management comes from a partnership with your healthcare provider, and one where you you know, become an advocate for yourself and the needs that you have. I hope you'll consider this idea of attack-based care, and you know, if it seems right to you, that you might engage MigrainePro and see if it's anything that will help you better understand acute treatment.